So welcome everyone for coming to CARE's Brain Trust meeting today. All right. So in the interest of time, maybe we can get going. So welcome everyone, and my name is Janice Tsoh, one of the MPI of CARE and UCSF professor here, and want to welcome you all to today's Brain Trust meeting, focusing on telling you about the updates and what is CARE Registry. So we have a full agenda today, and perhaps before we begin, we're going to go over some of the housekeeping logistics briefly. So first of all, we'd like to welcome everyone, and please feel free to use the chat to introduce yourself, your name, your affiliation, your location. It is not obvious with your affiliation, so please let us know who you are. And we will do the same for our CARE investigative team and community partners who are here, and want to thank you all for being here today. And also please mute yourself, except when you would like to ask a question, then unmute yourself. As you have noticed, this meeting is being recorded, so all the slides and the recording will be available on our CARE website. And for questions, because of the time, we're thinking that we will have your questions. We will save it for the Q&A, or we will do our very best. Our team will do our best to also try to answer your questions on the chat. So please feel free to use the chat as well to ask questions. But please stay with us at the end, because we will have the questions and answer, and also raffles. So I guess I'm jumping into the agenda already. So for those of you who's just joined us, welcome. Please introduce yourself briefly in the chat with your name, affiliations, and your location. So welcome again. So our agenda today, several of us are going to be presenting on various topics, and I will have each presenter to introduce themselves at the beginning of their presentation. So what we will be talking about today, we'll first introduce you and giving you an overview of CARE Registry, and also some updates of our registry data and how to use CARE. We'll also be sharing with you community perspectives on research, partnership with CARE, and we will also have a user testimonial on experiences with using CARE for study recruitment. Our last segment will be question and answer and raffles. Again, please stay with us toward the end, and we'll also have an evaluation of our events today. I also want to especially acknowledge all of our CARE investigative team, our staff members, our community partners who have been working very hard and playing an instrumental role in the implementation of and day-to-day operations of CARE. So thank you, everybody. All right, let's get into an overview of CARE Registry. So, and you may know already the background information of Asian American, Native Hawaiians, and Pacific Islanders, who are the fastest growing community racial group in the United States, currently comprised of nearly 8% of the US population. Our community has an extensive range of diversity, as you can see, from language, culture, immigration history, diet, social, economic status. The bar graphs on the right is really just showing you a lot of significant differences, even just in English proficiency. Such diversity underscores corresponding disparities faced by our diverse communities. Next slide, please. Now, despite AANHPI individuals are comprised of nearly 8% of our US populations, NIH-funded research between 1992 and 2018 that focused on AANHPI is less than 1% in terms of the budget allocation. Now, in Alzheimer's disease research centers, AA-NHPI participants constituted less than 3% of all study participants. Now, obviously, AA-NHPI are underrepresented in most, if I say at least many, clinical studies. This is not just a statistical concern, it's a reflection of broader disparities in research participation. Now, what can we do about it? How do we address it? Engaging AA and HPI communities in research can be very challenging. As you can see, the cultural linguistic differences, for example, we really need to, educate our partners and funders about the diverse needs and health outcomes, and certainly our community about the importance of research. Next slide, please. Now, this really speaks to the mission of CARE, which is also our community and academic collaborators feel strongly about, is to pave the way for meaningful inclusion of AA and HPI participants in research. Now, CARE was first funded by R24, currently a 5-year R01, both of which funded by the National Institute on Aging, NIA. I want to here especially acknowledge Dr. Vanta Park, who's in the audience, professor at UCSF School of Nursing. She is the one who conceptualized the CARE, the original CARE or CARE 1.0, and the sole PI of the R24 and currently MPI of the R01 or CARE 2.0, which we will be referring to a lot. CARE was first launched in 2020, October, during the early phase of the pandemic. The goals of CARE includes reducing the disparities in participation in ADRD, aging, caregiving, and other health issues across the lifespan of AA and HPI populations. Importantly, we aim to give a voice to our communities. We want to implement appropriate and innovative recruitment strategies in collaboration with our community partners to enroll AA and HPI adults who are interested in considering to participate in health research. Next slide, please. Now next slide, please. Yes, here are some of beautiful logos of our community partners and our community advisory board members and their organizations. You may recognize some of them already. These are the pictures that we took in the most recent community advisory board meeting. So many thanks to our partners again. Many of you who are also in the audience as well. All right, let's talk about CARE Registry. Who can enroll in the CARE Registry? Quite simple. Self-identify as AA and HPI adults, 18 years and older. Speak or read one of the 6 languages that we currently have available in the enrollment survey, which are English, Chinese, Hindi, Korean, Vietnamese, and Samoan. And who are those who are interested in considering participating in research, in health research. Now, in CARE 2.0, we're expanding our language options to include Japanese, Tagalog, and Ilocano. And CARE 2.0 enrollment will be launched shortly, and in the middle of October, that is our targeted date. We also place some efforts, actually important efforts to recruit older adults and caregivers, as you can see the slideshow here. Participants receive $10 for completing a survey that lasts about 10 to 15 minutes. And the survey asks about demographic backgrounds, health conditions, health behaviors, and caregiving experiences. Next slide, please. Let's take a look at the snapshots of our CARE enrollees. So as of September, we have 10,257 enrollees, participants of CARE. The slide shows you some highlights of the characteristics. Majority of them were born outside of the US. CARE started off as a California-based registry, and then we slowly expanded ourselves to nationwide registry. So for now, we have 85% of our participants from California. And wide age range from 18 years old to 101 years old. And something we're very proud of is majority of them, 80% of them, have not participated in any of the research previously before enrolling in CARE. So half of them are also have have limited English proficiency, and we have some 10% caregivers, and 14% of those indicated that they have experienced some ADRD related symptoms such as confusion, memory loss, and dementia, etc. And you can also see some of the language breakdown and also our cultural groups breakdown. Let's take a look at the next slide, please. All right, so you could see we have a really great growing registry of many enrollees, more than 10,000 enrollees. How are we connecting our enrollees to research opportunities? We need your support. We need your help. Care-supported recruitment. The procedures start like this. You see the QR code, everything is online, when you submit the request, and all the information is available on the CARE website. So I will just quickly go through that in the interest of time. Importantly, IRB approval is also required in terms of receiving CARE information. This is the layout of the process, starting with the online application, and then review of the study itself to see how CARE could best serve to support the recruitment as investigators received the IRB approval. CARE would be able to provide the potential participants by batches, and then that include name, language preference, contact information, and method. And importantly, I want to emphasize here on this slide is investigator responsibility, where investigators are required to contact, to make at least first contact with all the potential participants within the first month. And also, CARE needs to be informed about the outcome of recruitment for every registrant within 30 days of receipts. This is a very important data piece and our understanding really to improve our CARE-supported recruitment procedure, and certainly, including citations of investigator study on the website and citation of CARE. So more of these are on the website, and in fact, Dr. Joshua Grill will be talking more about examples of using CARE as the recruitment support. Next slide, please. As of August, CARE has supported more than actually 120 studies. And since we started the CARE-supported recruitment in January 2021, altogether, nearly 13,000 of CARE participants have been referred to CARE-supported studies, and more than 6,600 CARE participants have been referred to more than one study. And about some of the studies you can see here listed here, about 1/3 of the study have language support, at least English plus at least one AA NHPI languages. And also CARE provided letters of support to 20 investigators for grant applications, majority of them from NIH or NIA. And also we have one from Alzheimer's Association. And they are all our studies that are CARE supported for recruitment. They have a variety of funding sources that you can see from NIA, from foundations, and so on. And in terms of the areas of research, many of them are related to Alzheimer's disease and related dementia studies, and also health studies, and as well as there are other studies as well. At least half of them focusing on, all groups of AA-NHPI, and then another half asking specific groups of and AA and HPIs. So you can see this is like a diverse range of studies that we are supporting. And then now I would like to turn the podium to Dr. Joshua Grill, who will tell us more about examples of using Care Registry.
Great. Thank you, Dr. Tsoh. Let me begin by saying it's fantastic to see such a large number of people participating in this Brain Trust meeting. The goal of these meetings is to familiarize people with the Care Registry, which Janice has done so well, but also to help you think about ways where you might utilize the Care Registry in your own research, and that's my charge. So I am Josh Grill. I'm a faculty member at the University of California at Irvine and part of the CARE team, playing the role of MPI with Dr. Park and Dr. Tsoh. We can go to the next slide. I'm going to be brief, but I'm going to walk you through 3 possible ways that you might think about using CARE in your own research program. And those are to recruit participants to improve the diversity and inclusivity and generalizability of your study. To recruit participants who might serve as novel comparison groups in a study you're conducting, or to simply try to answer novel questions about the populations who are represented in the Care Registry. Next slide. So first, hopefully our audience doesn't need this reminder, but Dr. Tsoh already gave it to you, and I'll give it to you again. And that is that especially in dementia and aging research, AA and HPI communities are severely underrepresented. I myself am an Alzheimer's disease clinical trialist, and so I'm giving you a few examples from our clinical trials literature for Alzheimer's disease. 2 meta-analyses looking at studies conducted by pharma, the Alzheimer's Disease Cooperative Study, and then a literature review of clinical trials in our space. And what I'm sure jumps out at you is that these studies really lack in diversity. They don't represent the greater disease suffering population with Alzheimer's disease, and Asian Americans are particularly underrepresented if they're even reported as a category in these studies. And I'll just note that the Franzen paper actually included some trials that were conducted in Asia, and so these numbers overrepresent what we would expect to see for trials conducted just in North America. And so as an investigator conducting studies like these, I can think about using the Care Registry to try to improve these numbers and make sure that Asian Americans, Native Hawaiians, and Pacific Islanders are better represented in our studies. Next slide. This doesn't have to be for trials per se, but it is ideal to think about how you're going to use this as a source to try to enhance the diversity of your study. And you might also think about the means by which you will incorporate these participants into your study design. And I'm going to come back to that a little later. But so far, I would say that most of the people using the Care Registry have used it in one of these ways, including this one. You have a study, you submit your protocol to the Care Registry, and you receive a list of people enrolled in the Care Registry who meet the criteria for your study for you to try to recruit to accelerate your accrual, answer your question more quickly, and increase the diversity of your sample. Next slide. You could also think about using CARE as a novel comparison group for other work that you are doing. These types of studies might ask specific questions about how AA and HPIs or subgroups therein compare to others, in particular outcomes or attitudes or accessibility to resources, for example. On the next slide, you can see a schematic of what this might look like. There are a number of other registries that exist throughout the nation. And you can imagine trying to recruit a population of non-Hispanic white individuals from one registry, AA and HPI individuals from the Care Registry, and perhaps a third group from a third registry. And then you could compare those groups for, again, a variety of outcomes that you would want to examine in your study. For example, on the next slide, or sorry, I jumped the gun there. But for example, we do studies looking at willingness to participate in clinical trials or attitudes towards biomarker disclosure. And so one can imagine trying to recruit 3 distinct populations to compare in some of these outcomes. Next slide. Finally, you can imagine doing studies trying to answer questions specifically about AA and HPI communities, or as a collection of subgroups, by doing studies just in the care registry. So I've flipped the figure on the right so that instead of care sending participants to the investigator, this would be where the investigator might try to send a survey or another element of data collection to the care registry itself. And again, the variety of possible opportunities that would arise with this. You could complete a needs assessment for a grant you're working on by collecting some preliminary data from this. But it's also possible, especially given the size and diversity of the care registry, that you could complete a whole study by sending a survey to the care registrants. Next slide. Now, before I close, then this was our example of that, where you might have a hypothesis you wish to test in this population, limit to the participants in care who meet the criteria for your study, and then send an electronic survey out through the care registry to collect your data. Next slide, last slide. So before I close, I need to offer a couple of reminders and/or warnings about even some of the things that I have suggested. First, care is not a community-based or epidemiologic cohort. So we wouldn't want to use care as a mechanism to try to assess the prevalence of disease, for example. It really does still represent a convenience sample, recruited largely through community partnerships and other approaches. Those have been described in some papers that we have published. But I think that's an important caveat, that there is a bias associated with the care registry, as is the case for essentially every registry available to folks. And so it's best to implement rigor in the design of your study that you will recruit from care to try to address those things. So that might be a randomization, and a particular caution around comparing folks in care to folks from other registries, or even comparing subgroups within care to each other, because different partners were vital to the recruitment of those populations. And so we need to be careful about the conclusions we draw therein. That said, it is clear that care is a remarkable tool that we are thrilled people are utilizing and hope people will continue to utilize to increase the representation of AA and HPI participants in aging, dementia, and caregiving research. With that, I will close, and I will turn it over to our colleague, Quyen, who will walk us through the community perspective of care, and we'll come back for questions later. Thanks very much.
Hi, everyone. Can you hear me? Hello. Thank you, Josh. Hello, everyone. My name is Quyen, Vuong, Executive Director of ICANN, which is the community recruitment arms for care for the Vietnamese community. So next slide, please. Next slide, please. So basically, next slide, please. Yeah. So ICANN's mission is to engage, inform, and inspire Vietnamese American to raise the next generation of caring leaders. You may ask, what does raising children, parenting have anything to do with research, especially dementia-related researches? But it has everything to do with it, because the way the community works is that nobody cares about parenting until they have a problem. Therefore, we have to do a lot of things, a lot of activities to attract them. And a few of those have to do with health studies. And people, my community is very, very passionate about health. And so when we started talking about health for grandparents, they started to listen. Next slide, please. So so as you can see, the star there is to address the youth, right? But we have to build a foundation, the family foundation to support the youth. That includes the health for parents and grandparents. Next slide, please. So what inspired ICANN to partner with the CARE team is the opportunity to give Vietnamese Americans a voice in research. You know, we talked about parenting, right? I wanted, in doing parenting workshops, I want the parents to have the confidence and feel empowered to speak up, to voice their needs. Just as the same, we want them to do that in social services, in policy or politics, and especially in research, because as you all have seen, the voice of Asian Americans in general and Vietnamese American in particular in research is very, very, very small. So we believe that if we can help produce relevant information about Vietnamese American research, then the community can get back the research about ourselves, which will in turn help our health. Because we typically did not understand that. The community thought that, oh, you know, all the research, the scientists are like these like few Back to the Future scientists, guys who worked in the ivory towers with all their hairs like splitting out like this. And then they come up with the magical numbers to give the formula. What they did not understand is that we need their data in order to put back out the data that's applicable to them. So that's why in doing the community-based care research, what we've been doing is building the relationship between the academic partners like UCSF, Davis, UCI, and the community partners like us and the community. Next, please. So what we do is we do the current ongoing studies we've been doing with Dr. Vangta Park, like about 10 or 12 research studies, large and small, since 2017 when I first met Vang. I thought she has such cool ideas about research. And so we engage the community in that. And what we do is basically we outreach through all the different channels that ICANN does in our various projects. When we engage and educate the community on variety of issue like forum, you know, health fair, support group, radio. Right now, we just launched a caregiver support group for people and for Vietnamese people who take care of their parents who are, you know, who have dementia, and many of them also have Alzheimer. And it's through these kind of activities that we educate the community about the importance of their voice, and also kind of like destigmatize the fear of acknowledging that I do have issues. Because the more they see that others people are saying the same thing, the less they are fearful about speaking up. So and all of that leads to building lasting impacts about health in the community, the connection with the community, and the trust that the community has with us. And through ICANN, they trust the research studies. They started trusting the professors in the ivory towers of the, you know, the colleges and education institutions. So also, they also realized the power of their voice. What they didn't understand before is that they thought that if they say if a study that says, oh, the Vietnamese has issues, a very bad issue with smoking, then that makes the Vietnamese community looks bad. So we have come a long way in explaining to them that that is good. It's good to explain it. It's good to voice your concern, because that's how we are going to get resources to address the concern. So it's been an educational journey with the community as well in doing these community-based research with the academia friends, colleagues. it's a fascinating journey for me. So far that's what I have. And as you can see on the screen, on the ongoing studies we have, you know, a lot of it has to do with dementia related studies. So that's all. I can entertain some questions later. So right now I'll pass it on to the next section, please.
Dr. Han, we're gonna pass the baton to you. Thank you.
Okay, can you see my screen? I don't know if I'm sharing my screen.
Yes, but you'll need to turn on the like the full slide deck.
Yeah, okay. Okay, hello, good afternoon. Well, is it afternoon on West Coast? I'm Alicia Hong. I'm a faculty at George Mason University College of Public Health. I'm very happy here to share my experience of recruiting underserved Asian American dementia caregivers into a digital health intervention and using a recently completed We Care intervention as a case. Van and Marian already reminded me, like I only got 10 minutes, so I'm gonna skip many slides. I'm gonna go straight to what We Care is about. It's awareness enhancement for caregivers. It's a digital intervention delivered via WeChat, which is a very popular social media app used by about 92% Chinese-speaking people, including Chinese American, like Chinese-speaking smartphone users, including Chinese Americans. It's a 7-week program. Users subscribe to the We Care, like a business account or official account, and then they will receive multimedia articles or modules on their own WeChat social media app 6 days a week for 7 weeks. Users could also use group chat and choose for social networking and receiving peer support. They also receive location-specific resources. This We Care intervention is designed to improve their caregiving skills, reducing stress, and enhancing psychosocial well-being. And through 2022, we've piloted We Care 1 and We Care 2, and earlier this year, we finished a 2-year follow-up of We Care 1, and currently planning on the follow-up of the We Care 2. And here are some screenshots from the We Care, the user interface. So you can see, mentioned earlier, we have short video clips, audio recording, and pictures. We also have, so like 3 pictures on the screen. We also have the progress update for users. We used, on the back end, we have a user management system. We could track whether users open the articles we send them, when do they open it, and for how long. And our participants are Chinese American dementia caregivers. They need to actually take care of a family member or a loved one with ADRD and provide at least 8 hours of caregiving a week. And in our 2 We Care pilots, we've been working closely with Care Registry and some community-based organizations in our recruitment. In We Care 1, 13 out of our 24 participants were from Care Registry, and We Care 2, actually, the number was wrong. Later on, I'm going to share with you more than, it's actually 5, but there was some story behind that. Out of 48 were from Care Registry. In these 2 pilots, participants were quite, I would say, slightly different. And for instance, We Care 2 participants were older, and they were more likely to be spouse caregivers versus children caregivers, and a higher percentage of female caregivers as well. And our We Care 1 had a very significant outcomes in terms of changing. The primary outcome was depressive symptoms, and secondary outcomes were life satisfaction and caregiving burden. And we found the effect size was very significant with 0.89 for the depressive symptoms. However, in our We Care 2 pilots, those outcomes I mentioned earlier were not significant. In the pilot of We Care 2, we did observe the outcomes change in the direction we hypothesized. It's just we did not have enough power for that. And we also observed some positive change in terms of their caregiving mastery and positive aspect of caregiving. We, in preparing these slides, we actually looked into our data more carefully. We found participants from different recruitment channels actually have different characteristics. For instance, participants from care, they will more likely have lower English proficiency. Many of them speak Cantonese only, and then they will have poor caregiving skills compared to caregivers we recruited from Maryland and DC, for example. And these are just some quick observations. We're currently working on the data to actually compare the participant characteristics recruited from different channels. Care Registry, we've been working with them very closely in the 2 pilots of We Care. My team work closely with Marianne. We send them the criteria we need for our participants, and then they send us multiple batches of potential participants. And then we reach out to these people either via email or call or text messages. Usually people will respond by email. And in our We Care 1, we directly recruited 9 people from the Care Registry, and then additional 4 of these 9 people also introduced their friends, like their peers who were also caregivers, into our study. So that was quite a add-on gift. And then We Care 2, because of the timing of the trial, so some of the recruitment from Care Registry had to be paused because we had a starting time for the 2 batches of participants. That's why we only got 5 participants from Care Registry. But overall, it was a very smooth process working with Care Registry. We were very, very grateful for their support. So this is final slide. Some from our own experiences, when working with underserved populations like Asian Americans with limited English proficiency, we need to give them very specific information. Many of them do not have the concept like trial. Like, what do you mean by trial? What do we mean by intervention? They want to know what exactly you want me to do. And then what do you mean baseline follow-up? Okay, tell me what do I do now? And then for how long? And then what's next? And it would be nice to have a simple website and with the up-to-date information. For instance, sometimes if there's a change of project staff, and then people might be confused. And most of our participants are older adults, and many times they have a very long story to tell you about their life experiences. So be patient with their stories and then document their concern. And we also know that community-based organizations, even in the same region, I'm in the Washington, D.C. area, Northern Virginia and Maryland, we are only 10 miles apart. And I know that those community-based organizations, sometimes they don't talk to each other. And then it's kind of in their silos. And then I think for Chinese community, especially, I know that people hang out with their own group. They don't really mingle together. And sometimes they have their own info, kind of like a chamber of echo of chamber, whatever we say that. So it's very important you understand where your participants come from. And finally, I like to emphasize or share my own experience, a registry like a Care. It's very, very important or very critical for clinical research, especially when we need participants from underserved populations. Without Care, I could not jumpstart my We Care intervention trial, like the We Care 1. We were able to recruit 13 out of 24 participants in our first pilot. It would from Care. Without that, it would be impossible. So I just big shout out to the Care team, and that would conclude my talk.
Thank you so much, Dr. Hong, and congratulations to your studies as well. And we're just so pleased to hear your experiences and also the pearls that you just shared with us about lessons learned on recruitment. And part of CARE is the collaborative learning education process that we are in it together. We're doing it, learning together as we grow. So thank you. Last but not least, here for this part of presentation portion is I want to represent our team to acknowledge all of you for being here and thank you for coming to this meeting, to this session. And also thank you for your interest in CARE, and certainly to all of our registry participants and also those of you who connect the participants to the research opportunities as well. You see, we have a big team here from UC San Francisco, UC Davis, UC Irvine, and Stanford, ICANN, CSU East Bay, University of Hawaii, and certainly our wonderful community advisory board members and many of our community partners. So I want to thank everyone. CARE belongs to all of us, all of you here. And with your help and support, we hope to continue. We aim at, getting the voice of our AA and HPI communities being heard and promote the representation of our diverse communities in more and more clinical studies, health-related research.